Yes, we are at the Dallas VA up until February of this year when we moved to the Garland VA. So currently we're at the Garland VA in Garland, Texas. So before I get started, I want to ask everybody something. Look around. What is something we all have in common? Well, that, yes, but also as humans, every day at some point we look at ourselves in the mirror, right? So imagine doing that and having a skin condition. So that's why I'm here to present phototherapy to help improve that and also improve skin conditions. So basically this is about phototherapy, not only in the clinic, but also the patients and veterans can have access at home as well. So just for the learning objectives, just end of the presentation, nurses will be able to explain what phototherapy is and the purpose of it. Should be able to explain the advantages of home phototherapy and what it involves, and also compare phototherapy versus biologics. So if y'all don't know what biologics is, it's the injections you see in commercials like N.O.V.A, and Taltz, including the cost differences. So what is phototherapy? So phototherapy is treatment that involves exposing the skin to ultraviolet light on a regular basis to treat skin conditions such as a T-cell lymphoma, another name for it is mycosis fungoides, psoriasis, atopic dermatitis, eczema, vitiligo, etc. So people are psoriasis, it's when you have the red patches that are red, inflamed, irritating. Atopic dermatitis, a lot of it inflammation, itching, same with eczema, and vitiligo. You probably see a lot of people with darker skin have those little lighter white patches on there, that's the vitiligo. So there are three main types of phototherapy. The first one is N.O.V.A. It stands for Solar Lens UVA. So what that involves is a combination treatment which consists of Solar Lens. It's a medication that's applied right prior to the treatment, and then they expose the skin to the VA light. So narrowband UVB, and this is the type of phototherapy we use in our clinic. It involves repeated controlled delivery of the narrowband region of the UVB spectrum, and most widely used due to its safety and effectiveness. So this presentation today is mostly going to evolve around narrowband UVB. And also regarding the VA, before I came in, they did do UVA for a while, but like I said, now we're 100% narrowband UVB. And the other UVB is broadband, which is not used as much due to exposure, and the treatment times are shorter and result in longer periods of remission with narrowband UVB. And periods of remission are pretty much when the patient is able to be weaned off of phototherapy. As in they've been on it, weaned, and then that way they can have their life where their skin condition is controlled and they have a better quality of life. So the mechanism of phototherapy. So several skin conditions are caused due to immune system problems. It could be the immune system is suppressed, where it mistakes the skin as being foreign and attacks it, or the immune system works too well. So, for example, like with psoriasis, it involves infection-killing cells that attack healthy cells by mistake, causing the redness, inflammation, and pain. For vitiligo, the immune system attacks the melanocytes that cause the melanin, the dark color in the skin, by mistake, causing those white, hypopigmented macules and patches. So, with narrowband UVB phototherapy, it induces a skin-specific immunosuppression without the toxicities of traditional systemic immunosuppressive agents like the biologics or injections. So pretty much phototherapy it calms down the immune system, but doesn't suppress it to where it's going to increase the patient to have an increased risk of infection. So one of the skin conditions that I mentioned is mycosis fungoides. So mycosis fungoides, it is a rare T-cell lymphoma blood cancer that happens when the white blood cells, called the T cells, transform into malignant cancer cells that affect the skin. So, yeah, it says a rare blood cancer. I spoke to Dr. Saxon Daniels, who's our current phototherapy director, and I said, I know they said it's rare, but when you work on our clinic, it doesn't seem rare because about half of our patients we treat in clinic right now have mycosis fungoides, but it is, compared to the general population, it is rare. There is no known cause exactly what causes it, but they do believe genetic mutations may play a role. Also, mycosis fungoides, if it's not treated, it can spread to other parts of the body, if not treated, like the digestive system, liver, or brain. So it starts over in the skin, and we diagnose it with using a biopsy. So if it's not treated, it can advance, it can get into the lymph nodes and advance into the organs. So what we do is we have it treated, and then they see the dermatologist every so often, and they make sure they do certain tests to make sure it's not advancing. And the reason why I have golden treatment is, especially when I first started in phototherapy, Dr. Rachel Casey, she's a dermatologist over at the Fort Worth Dermatology Clinic at the VA. She told me it's the golden treatment for mycosis fungoides because the success for it is astronomical. It is very successful and a very good treatment for it. So this was a quote from the Lymphoma Foundation. So it says, according to Continuous Lymphoma Foundation, it has been reported phototherapy having a 60 to 90% effectiveness rate, depending on the stage of lymphoma, thickness of lesions, and baseline skin color. Remissions have been documented with light therapy after completing a treatment course. Some remissions have been reported as lasting a year or more. So I do have a patient that we treated when we were at the Dallas VA that had mycosis fungoides. We were able to wean them off before we left in February. She's still off treatment. She just saw the dermatologist just lately and she's good to continue. She had no reoccurrence, no flare-ups. They said you're good to continue being off of it. All right, so what does narrowband UVB treatments involve? So as you can see, I have a couple of photos. That first picture up there on the top left, there it goes, this one right here. That's what our full body looks like in the clinic. As you can tell, they stand in it. It's like a 360. There is an opening at the top so they don't feel claustrophobic. And there are hand bars in there for the bottom. So you can see it's the lights all around it. Now on the right, that's just an example. They do have to wear protective eyewear. That is an example of glasses, but we also provide it looks like swimming goggles, but they are UV protected. Now the bottom one, this one, now we do have units that can specifically treat the hands and feet. So to give you an example how it goes, ladies, when you get your hands, nails, and feet done, and then you go into the dryer, put your hand under, that's kind of how it is when they go and treat their hands and feet. We do have some patients that treat just their hands and feet or do full body, so we do offer both of those. And this last photo right here just pretty much shows, you see what the patient goes through when they're inside the booth. So they are by themselves, nobody else goes in there with them. All right, so biggest thing is safety precautions. Again, like we said, the protective eyewear. We do provide it for you, and specifically ours, we have it from the company. So the reason why to make sure to wear the glasses is because if they end up burning their corneas, that could be what can happen, and also it increases the risk of cataracts. Now, if you have a patient with vitiligo and it's affecting their eyes, you can treat them without the goggles, but you need to strongly tell them they need to keep their eyes closed. Regarding a face shield, so the face is one of the most sensitive parts to the light. So depending on, it's not saying it has to be, but in our clinic we do a face shield. The exceptions are again with vitiligo or if they have activity on their face, and then we just see how well they tolerate it. Genital protection. So that's one of the things we do. So for men, depending on if they have any activity on the back of their bottom, we either have them wear underwear, they can wear boxers, briefs, or have them wear a thick sock. And for ladies, we have them wear underwear. The key thing is just to make sure they wear at the same time each treatment. So mineral oil, we provide that in our clinic. So we have them apply this right before they go into the booth, especially on the areas of their skin. So mineral oil, what it does is it helps the treatment be more effective because it helps the light get deeper into the skin for it to work. So we do provide zinc oxide, which is the main ingredient in sunscreen. We have it put onto their nipple and areola areas, and their lips as well. Again, those are very sensitive to the light, and they can be extremely painful at birth. So this is the thing, we have to make sure there's one full calendar day in between your treatments. Now I have read sometimes they have said it can be done 5 times a week, but in our clinic we encourage to have one full day in between treatments. So currently we treat Monday, Wednesday, and Friday mornings. The reason why you want to make sure there's a full calendar day because you want to allow the skin to recover from the treatment. So this is very important. Always remember to do the same thing for every treatment to prevent burning. So I'll explain a little bit. So we start our patients at a low dose and we gradually increase each treatment. Now, if any part of their skin is covered for one treatment and then exposed on the next, that can increase the risk of burning. So that's why we highly strongly recommended to make sure the patients do the same thing for each treatment. All right, so side effects and requirements. So back to the eye damage if they don't wear the protective eyewear. So yes, side effect is sunburn. So usually we monitor our patients when they come back. We ask if they have any issues. If they come back with a sunburn, depending on how it lasted, so forth, we may have them skip a treatment or reduce their dose. So they do have it on skin cancer. Now for UVA, yes, it does increase the risk for skin cancer. However, with narrow band UVB, there is no legit studies that say that it increases the risk of skin cancer. Dryness, because it is kind of using the heat, so we encourage our patients after their treatments to put lotion or moisturize their skin to help reduce that. And also increase burning risk with photosensitive medications. Now there are medications, have the photosensitivity as a side effect, which increases the skin's risk to burn. So like antibiotics, some NSAIDs. So what we do is in our clinic, each day we treat the patient. We look in their chart and see if they started any new medications. And of course we do ask them too, because sometimes they see a provider that's outside the VA that we don't see in their chart. So we do ask them if they've taken any over-the-counter medications the last 24 hours, and if they do, and then we have it in our protocol, which is, so if they started a antibiotic-sensitive medication, we just reduce their dose a certain amount, and we hold it at that dose until they complete the regimen, because a lot of antibiotics are short-term. Now, if they start a new long-term one, then we decrease it by a certain amount, keep them at the dose for about 2 to 3 treatments, and if they tolerate it fine, then we go back to the usual regimen. So requirements is minimal assistance. As you saw in the photo, they are by themselves, so they need to be able to stand by themselves. Now, there are some exceptions. If the patient uses a cane, they can use a cane in there. Of course, we do have the bars in there for them to hold on to for stability. Now, there is the option, you can have them sit in the treatment. The only disadvantage is they're not going to be able to treat their whole body. Next one is we have tell them to try attempted topicals or oral medication. That's normally the first thing we do. If either they work or they work for a while, now they're not working so well, then that'll be the next step with phototherapy. And the biggest thing is to stay consistent with treatments. So if a patient misses 1 or more treatments, their dose is going to be affected. If they miss 1 treatment, we treat at the previous dose, and then if they miss more than 1, depending on how many treatments they miss, we decrease it. So of course, the biggest thing, half the battle, is coming in for the treatments, and that's what I tell all of our veterans, especially when they initiate it, that it's half the battle. Now, we do tell our patients to limit their sun exposure, because even though, not exactly the sun, but you are around ultraviolet light. So we tell our patients if they are going to go outside to limit their natural sun exposure to no more than 30 minutes a day, because to help reduce the chances of burning. Now, like I said, they are educated to stay out of the sun, but if they do have to go outside, they are informed to wear sunscreen, SPF 30 or higher, wear sunglasses, hat, and sun protective clothing. So I know a lot of patients, but we do tell them tanning beds are prohibited, because tanning beds use UVA like the sun, and that's especially going to cause burning and stuff. So we tell them no tanning beds. Now regarding with dosing, as you can see in the picture, you see it says skin types. This is called what we said based on a Fitzpatrick skin type. As you can tell, the higher the number, the darker the skin color. So what it is, our dosing that's in phototherapy is in millijoules. So we start at a low dose depending on the Fitzpatrick skin type. So like 1 through 3, we would start them at 200 millijoules, 4 and 5 start at 250, and 6 is 300. So some clinics do what's called using the minimal erythema dose, med dose. So they take a part of the patient's skin, expose it to some of the light, and have them come back the next day to see how they reacted. They want to get to a light pink color. So once they do that, then they'll say, okay, we're gonna do 30% of this med dose and so forth. Us, we don't do that. What we do is, again, depending on their skin type, we have to start at the dose, and we increase each treatment by 15%, depending how they tolerate. And we do not go any higher than 5,000 millijoules. Optimal phototherapy says 2 to 3 times a week, but it's better with 3 times a week, because it helps the patient to get to that higher dose to treat their skin condition. So when can someone be weaned off? On average, it takes 30 to 35 treatments to get many skin conditions under control. Could be less, could be more. Now, once the skin condition is stable, depending on the dermatologist, they can reduce the number of weekly treatments. For example, they start them at 3 times a week. They can say bring them down to twice a week, then down once weekly, then to every other week, and then stop. If anytime during this weaning off they start flaring up, then they go back to what they were doing before they had it controlled. So periods of remission can last for years. If the skin condition ever flares up during that time, they can restart phototherapy treatments. There is no max number of phototherapy treatments someone can have in a lifetime, so it kind of depends on the patient. Now, if it gets up to a certain amount, then they're gonna see, okay, is there a reason to continue them on, or they benefited it? Of course, treatment plan is patient specific. So, we had a phototherapy template note already in there. The thing I discovered when I came in, there was no tracking data on the patients, as in how many of each diagnosis are we treating, and how many patients are finding improvement. So earlier this year, we updated the phototherapy template note and CPRS so it is accessible, incorporating radial buttons and health factors to have data tracking. So kind of, I know a little bit, but like at this top part, that's the diagnosis, like the mycosis fungoides, atopic dermatitis. These are some of the most common ones we treat, and of course other, if it's another one that's not listed. And there is the Fitzpatrick skin type, 1 through 6. So also the other thing too is, so like this one we do an assessment, a lot of the times we do have for their first treatment. And then you'll have no improvement yet, which a lot, it does take several treatments before you start seeing a difference. So we tell our veterans, don't get discouraged if you're doing this for 3 weeks and haven't seen anything yet. It does take a month or 2 on average before we start seeing any improvement. So we do treatment, we do involve UVA and the others just in case if someone else is doing those other ones. So right here, body, we treat their feet and hands, sorry. And then we have the other one here on the right side top, date, what's the treatment number, and we do put the time it took for the treatment and the dose. And then we document safety precautions and the plan, when their next treatment is, if we go up 15%, or is there a specific increase we do for that particular veteran. And then at the bottom we have total, which is how many millijoules they've received the whole entire time they've been on treatment. So these are a couple of the graphs to show how, with updating this phototherapy template, we are able to have data tracking. So as you can see at the top left graph, this diagnosis treated in June of this year. So that big light blue part, that's the mycosis fungoides, the T-cell lymphoma. Like I said, at least about half of our patients were treating for that. So that does show how many we have treating with that and other skin conditions. And then the bottom right chart has where it shows how many patients in June of 2024 had no improvement and had improvement. Now please keep in mind for the no improvement, like I said, it's going to take several treatments before you do see improvement. So no improvement doesn't mean necessarily the patient didn't benefit it. It just meant when it was charted, it was at the very beginning of their treatment course. So, as we have it in clinic, we also have home phototherapy. So, home phototherapy involves the patient doing the narrow band UVB treatments at home, depending on the areas being treated. Now, the first picture on the top left, that's the unit we use for the full body. So it is different than the one we use in clinic. So that one is like a cabinet style, so they'll treat their front and then treat their back. The advantage is it doesn't take up as much room. Now, the one underneath it, just like the one I showed before, we do have that as a home unit to take. I usually order it if only they're treating their hands, because the unit is pretty heavy and hard to use. So if it's just treating their hands and they want to take that one, I let them go order that one for them. So this one right here, so this particular unit is called the N.O.V.A. The advantage of it is that it helps treat the more localized areas. So let's say you have a patient who has a skin condition, it's not all over their body, it may just be on their arms or their legs. They can use the N.O.V.A. to treat that little area. And then this one on the bottom right, that's the one they use for hands and feet, that's a lighter one. So as you can see in the photo, they have the one where they put their palms and then flip them over. And so with their feet, they would put their feet on top of the acrylic, and also it has a little turn. So in case the patient doesn't want to turn their palms over, just treat above it, they can do that. And move the unit over on top, so it's treating on top. And they can do that for the hands and feet. So in our clinic, we do require the patients to come in if they never had phototherapy before, to at least undergo 12 treatment with documented evidence of improvement in the clinic to qualify for our home unit, unless authorized by our phototherapy director. Now, we do let some exceptions come because we know our veterans drive a long ways to some of our VAs to get treatment. Or it can be if they have issues. I have a patient who has chronic health issues and can't always get up there. So I asked our phototherapy director, can we get her a home unit? No problem. So when a patient qualifies for a home unit, and they agree to, we do training, which is provided either in clinic or VDC, or VA Video Connect. So we can provide it through a virtual, so they don't have to come to the VA just for that. So also we have a treatment plan, like the company we have, they have an online treatment plan. We can have email to the veteran on their consent. And we do refresher training when the device is delivered and assembled, especially regarding entering a treatment into the device. So when they enter the treatment, there is a specific controller mode, we'll get to that slide in a second, that we help teach the patient how to put the dose in. Now with that, also the treatment plan does incorporate a link to a video that shows how to put the dose in. So if patients go through and then aren't so sure, they do have a resource to go back and look. So there are 3 controller modes that these home units come in. First one is in time mode, which is the dose in minutes and seconds. So with those, there's a way you start in like a minute and then increase by 15 to 30 seconds. They also have a chart that they have to follow. Dosimetry mode, that is the most common one that we use for our units. The only exception for the N.O.V.A. one that we use, it only comes in time mode. But all the others do come in dosimetry mode, and that's the one we mostly use. And that dose is in millijoules. So when we instruct our patients how to do it, instead of doing the percentage, we just tell them to start at a dose and then increase by 100 millijoules, depending on how well they do. Now, can they go down if they say 100 is too much? Can I do 50? Absolutely. We just tell them not to do more than what we told them to do with going up each treatment. And it's easier for them to calculate so they don't overdose themselves. And then the next one is guided mode. So basically it's a dose based on reaction after previous treatment. So the guided mode, when the veteran comes in to do their treatment, it's gonna come up on the screen saying, did you burn or have any issues with the last treatment? If they say yes, then it goes on to tell them what to do. Does it reduce the dose, hold the treatment? If no issues, then the machine does it going forward. All right, so these are some of the biggest benefits with home phototherapy. So you do treatments in the privacy and convenience of your own home. So you are on your own schedule. You do it that works around it, because of course a lot of veterans, a lot of them are still working, or they have lives, they have duties, responsibilities. So they can do it when it works for them. Because when they come in the clinic, time doesn't always work best, especially if they have other appointments. Decreased travel expenses. Sure, a lot of see our veterans that are staying any travel pay. Sometimes some of our veterans don't get travel pay. Well, they also don't have to pay for gas and having miles on their cars. Not missing work. We do have veterans that are young that are still working. I even have one veteran, unfortunately, has to cancel one appointment each week because he gets busy with work. So that's another benefit, is that they can do the treatments at home and not have to modify their work schedule. And the biggest thing is, can result in patients pursuing this treatment before trying more expensive options like oral immunosuppressants or the biologics, the injections. All right, so this one part is describing is comparing home phototherapy versus biologics. So this is a chart showing the cost of how much it's going to be within a 3-year span of treating one psoriasis patient over a 3-year period. So as you can see in the first one, that's the phototherapy, home phototherapy. First year, you can see there's not a difference between the first and the second, and the third, maybe a little higher, but usually that's if the device needs to have any tweaking, calibrating, fixing, so forth. The second graph is oral medications. As you can tell, it starts at $55,000, goes up to $110,000 the second year, and up to $165,000 the third year. And then for the biologic medications, first year is around $74,000, second is $143,000, and the third year is up to $213,000. I don't know about y'all, but I'd rather pay the $6,000. So also, one of the biggest concerns people also have is regarding it is the safety and efficacy, because there is no big studies that show how safe and effective it is. And this gives an example. Again, it compares again with the price for the first year cost of treatment methodology. Again, for phototherapy is about $5,900, oral treatment $44,000, biologic treatment $74,000. So the home phototherapy devices are a one-time expense. There are no yearly medical tests required, unlike biologics. Biologics, we have our patients go in to get blood work. They have to do a TB or quantiferin test every year to make sure they have not had any case of getting tuberculosis. There's no additional medication required to combat adverse reactions, unlike biologics. So they come in, they said they got a little sunburn, treat them with like N.O.V.A, topical medication they already have to help support, unlike biologics. So if you take biologics, suppresses your immune system, you have an infection. Now you gotta go to the doctor to go pay for antibiotics. And also is the safety profile. It is safe for pregnant women. It is safe for children. We don't treat treatment in our clinic. We don't treat children in our clinic, but phototherapy can be used for children. And it is safe for immunocompromised patients, because of course, you don't want to give them biologics when they're already immunosuppressed. So it's a good phototherapy is a good treatment to use for those type of patients. So the side effects are typically rare, mild, and most importantly, external. It is safe for children, the elderly, pregnancy, and patients who are HIV positive or diabetic. Most common are occasional erythema and dry skin. There have been no deaths reported to the FDA due to treatment of psoriasis with ultraviolet therapy. And home phototherapy is FDA cleared and is covered by Medicare and some insurance companies. So this is a quote from Dr. Joe Galfin. He is a dermatologist over in Pennsylvania who did a study that I'm going to talk about in a second, and this is a quote from him. Office phototherapy is 10 to 100 times less expensive than biologics for psoriasis, and in head-to-head trials, it's about as effective as N.O.V.A, I always call the brand name, I can never say the generic, N.O.V.A, and achieves better patient-reported outcomes. So this is a chart comparing the N.O.V.A and UVB and the use of other biologics. So when it says percent of patients to reach PASI 75. So pretty much I just want to reach a level to where their skin's cleared or almost cleared. So as you can tell, the first column is about cutate psoriasis and plaque psoriasis and the time period. So as you can tell, compared to narrow band UVB, all those percentages on that first column are lower. And then, as you can tell for the time period, with narrow band UVB, time periods on average 7 to 10 weeks. You can tell for the others, you don't start to see benefit until at least 12 weeks. And the biggest thing, as mentioned before, for the year 2016 to 2020, there was 29,789 deaths related to the biologics. And the lovely number we love to see from phototherapy is 0. So, of course you're thinking, well, if this treatment is so good, why is everyone no? Well, that's a good question. Health plans often unintentionally push patients towards more expensive therapies, including biologics, by limiting access through excessive copays or denying coverage for home phototherapy devices. I have a patient in our clinic that unfortunately the insurance won't cover a home unit for him, and he qualifies, like he would qualify medically to get one, but he can't because of insurance issues. And concern of the increased risk of skin cancer. So a lot of people think, oh, it's going to increase the risk. There is no legit studies that say narrowband UVB increases the risk of skin cancer, including the Scottish Health Service. They revealed that narrowband UVB has no significant association with malignant melanoma, squamous cell carcinoma, or basal cell carcinoma, which are 3 of the biggest types of skin cancers. So the study I mentioned earlier, this was a study, Dr. Joel Gelfand was one of the head people of it. So this light study compared the efficacy of home phototherapy versus in-clinic phototherapy. So, this thing, did you know? Before now, there have not been large-scale studies of phototherapy at home for psoriasis and other skin conditions in the US. As a result, clinicians are often uncertain about prescribing it, and insurers, especially private insurers, often don't want to pay for it. Again, yes, home phototherapy is covered with some insurances, but not all of them. And according to Dr. Gelfand, office-based phototherapy is not available in 90% of counties in the United States. That's not just the VA, that's all of them. So what did the light study do? So it was a patient-centered study that tested the hypothesis that narrowband UVB phototherapy of psoriasis at home is non-inferior to office treatment based on outcomes that matter to patients, clinicians, and payers. So it involved 42 sites in the US that enrolled 783 patients aged 12 years and older who had plaque or cutate psoriasis and were candidates for phototherapy at home or in an office setting, aka in the clinic. So researchers evenly arranged the patients by their skin type, the Fitzpatrick skin type 1 through 6. Collected data from medical records from apps on patient's cell phone, which captured the data. And study participants randomly assigned 1-to-1 to office or home-based phototherapy for 12 weeks at doses recommended in the 2019 American Academy of Dermatology and National Psoriasis Foundation guidelines. All right, so these were the results. So the improvement in health equity. 25.6% of patients in the office-based phototherapy group achieved a physician global assessment of 0-1, which is clear or almost clear, compared with 32.8% of patients in the home-based phototherapy group. So with that, the home phototherapy group had more improvement than the office. And the second one, 33.6% of patients in the office-based phototherapy group achieved a score of 5 or less, which means small to no effect on the patient's life on the dermatology life quality index, compared to 52.4% of patients in the home-based phototherapy group. So again, people with home phototherapy, the treatments worked, they had a better quality of life. So, and also regarding that adherence to treatments. So of course, you know, a lot of us nurses, we have patients who deal with that are compliant or not compliant. So patients in the home-based phototherapy were more adherent to treatment compared to those in office-based phototherapy. So it was a mean of 26.8 sessions compared with a mean of 17.9. And the 26.8 was the home-based phototherapy. So this is a quote from Leah Howard. She's the president and CEO of the National Psoriasis Foundation. Data from the LIGHT study strongly supports the need for elimination of copays for phototherapy delivered in the office and the need for better coverage of home phototherapy machines to improve patient health outcomes for all populations across the United States. So overall, my plan is we want to expand phototherapy throughout all VAs. I don't know if anybody out here works in the dermatology clinic over in their area or knows the dermatology clinics. A lot of them, some of them I know have phototherapy. I don't know if y'all have any that don't or know anybody that do, but my plan is to help expand it throughout other VAs, or at least increase the knowledge so the patients have this as an access. They have an access to use this treatment, especially for the immunosuppressive veterans, that also this can help. I have seen this be effective. I have a patient that I treated that has psoriasis. And he had been on phototherapy treatments for a while. He has a home unit. And I'll never forget when he told me, he walked up to me and he said, I can now wear shorts without being self-conscious. When you hear that, for nurses, you know how it feels. So it is very beneficial. I've learned that it's just not very well known and so forth because there is no concrete studies to show how effective this treatment can be. Thankfully, Dr. Joel Gelfand did the LIGHT study, which hopefully now that'll show how safe and effective this treatment is. So also with expanding phototherapy to other VAs, veterans will have an added treatment option and easier access with shorter drive times. So also, since I told you we moved to the VA in Garland, we are the only VA hospital or clinic that provides phototherapy in the North Texas area. So a lot of our patients, I have sometimes issues. They don't want to drive over to Garland VA 2 to 3 times a week. And then if they qualify for community care, and the problem that I've encountered several times, then we send them out to community care. Yeah, they send them out to a dermatologist, but it doesn't necessarily mean that dermatologist has phototherapy. They have other treatments. So that has been an issue I've encountered several times. So I've started to make a little list of providers in other areas that do provide phototherapy. So we have to specifically mention the provider that does it to the dermatologist that put in the consults. So also, we're hoping to expand also not only to have in-office phototherapy, but also home phototherapy so patients can have more effective at their own home and also increase their quality of life. And then the biggest thing we know back several years ago, isn't it happened where the VA hasn't been given the best image? And I know over the years we've all gradually tried to improve to show that we do support and care for our veterans. So also with this can show, hey, we have another treatment access that works and we care for y'all. Should phototherapy only be available to veterans? Well, this is probably a long time in the making, but my goal is to, due to phototherapy only available in 10% of counties throughout the U.S., we recommend to have phototherapy clinic in private sectors throughout America to provide treatment to non-veterans. I know our top priority is the veterans, but seeing the specific treatment and seeing how also it can help, because if we could expand over into the community, when our patients qualify for community care, they also have more access out in the community where it's not a struggle trying to find another dermatologist that does it. Alright, so these are just some people I got permission to present the data: Tracy Hartman, Julia Brown, and Dr. Joel Gelfand. I actually sent my presentation to him to review it all. And Tracy Hartman, she is the Vice President of Consumer Markets over at Garland. Julia Brown, she's a phototherapy product manager at Garland. And Dr. Joel Gelfand, he's leading professor of dermatology and of epidemiology, director of psoriasis and phototherapy treatment. So these are, if any of you want to contact me, learn a little more information or so forth, there is my email, katherine.allen@va.gov. The other one is the way to contact me over at the Garland VA. It is 469-797-2100, extension 26509. Now I tell my veterans, I only get my number out really for my phototherapy patients, because sometimes when they try to call for help, it doesn't get to me right away or so forth. So, but if you do want to contact for any questions, that is my contact info. I'm more than happy to give you more information or let you know what we do with our clinic. So I'll have that up for a minute if anybody wants to write that down. All right, any questions, concerns? So my clinic, we have currently our max we have is 16 patients. Now, every single patient's care counts. Unfortunately, it does come to priority. If a patient comes in with mycosis fungoides, they're going to be a higher priority than somebody with vitiligo, unfortunately. So if I cannot get them in a week or two, then I tell the dermatologist to refer them out to community care. But usually, if I have more people want to be in clinic, then I review the schedule and see, okay, which ones could work for home phototherapy. I have the discussion with them, and more times than not, they do get interested, because just hearing them, they don't have to come up there 2 to 3 times a week. That works.
Hello. Excellent presentation, good energy, good eye contact, good voice, volume, Toastmasters. My question is, how long are the patients in the full body? Is there a difference in time period between home and clinic?
Great question. So this also goes back to when we had the move from the Dallas VA to the Garland VA. So when I came in and joined the clinic, we had 2 full body booths. One that was full narrowband UVB, one that was half UVA, half UVB, back to when they did treat with UVA in the clinic. Well, with that booth being half UVA, half UVB, since not all the wells were UVB, the treatments were longer. If I had patients up to 5,000 millijoules, they were up there almost 30 minutes. So with the move, and I got approval by my phototherapy director, because the previous RN lead, we had been in the works to move to Garland since 2019, so we had a lot of stuff already in the works. But anywho, she bought another phototherapy booth that had full narrowband UVB. Our goal is to have 3. So I spoke to my phototherapy director and I said, can we just later on, once there's budget, can we get a 3rd full narrowband UVB? First, Dr. Saxon-Daniels told me she does not plan to use UVA in the clinic, and also it would help reduce the time, because with the full UVB booth that we had in Dallas clinic, when they got up to 5,000 millijoules, the highest was at 9 minutes.
That was my question, my concern with that open booth, that they would have, they would have a lot of unnecessary exposure, to other parts of the body too, the way it looks like it's set up. And haven't done any data, haven't start collecting any data on those type of things, since you have such a small sample size.
So it has been some more. We do more patients. Like I said, that was from June, we're getting in. So, but in regards to exposure, it's enclosed. So the lights coming out on the top and the bottom. So if you're in there, and also with the specific boost we have, it has a little see-through to make the patient is fine, and that's full UV protected. Now, when you have like a hands and feet unit, as long as you're not looking straight into the light, you're good. Like in our clinic, I have them put a towel over it, so also it covers the light, and also you're not looking straight into it. So a lot of, especially we had a phototherapy workshop for also phototherapy nurses, and it is known that UVB light cannot go through cloth.
But that, as far as the unnecessary exposure?
No, not that I'm aware of. And also, when somebody said how long the treatments are, yes, it can go up to 9 minutes, but first several treatments, especially with the new booth, the first one can start as low as like 20 seconds. So we tell our patients for the first several treatments, it's going to take longer for you to get ready for the treatment than the treatment itself. Okay. Yes, ma'am.
Great presentation. I'm not a what we do as nurses, a lot of it is data collection, right? We're statisticians at heart. And I love how you incorporated health factors and data collection into the electronic health record, because if we don't have that, then it's really difficult to justify what we're doing, who we're doing it for, what the outcome is. So great job with that. My question is that something that you're using locally? Well, obviously it is. Is it something that is being spread across VA as a national template? Because then we can actually compare apples to apples versus this data just being collected in this isolated location versus the VA at large.
Yes, it should be accessed nationally. Great question. So I didn't officially get approval until earlier this year. So yeah, some of our sample sizes are still going to be on the small side, but also I did this so it can be accessed VA-wide. And also I provided the template. So if y'all have one that's not there, like I said, you're free to contact with me and I can show you or send you exactly what was on the presentation. If you want to make updates on your phototherapy template, work with your the ethics and with the information and have them and just update it. For if you want to have it the same, you can tweak it however it is in your clinic. I am more than happy to share the information. But yes, good question. So that's what we want, is to have it accessible throughout VA-wide. Any other questions? All right, so before I walk off, I just want to thank everybody for listening. And just one more question for y'all to think about. So we all see with the advancement of AI how the future is going to change. Isn't it time we make the changes ourselves and be part of that change? Thank y'all very much.